women and men struggle with weight gain, fatigue, low libido, muscle loss, and blood sugar issues. Can hormone replacement therapy help?
Absolutely. Shana, so I started my practice about 21 years ago, and this was after the Women's Health Initiative study had shut down, really scaring so many people about the risks of HRT or hormone replacement therapy. S- Um, and unfortunately, the evidence was, um, you know, over how do you say? They were the results sorry, I'm a little nervous. The results were overinflated, let's just say that.
Okay.
Me
Oh,
Relative risk versus absolute risk.
okay. And can you explain to our listeners why that's important, relative risk versus absolute risk, as far as hormone replacement therapy goes?
Yes, so the relative risk is actually a much more accurate measure of the risk of HRT potentially causing breast cancer, strokes, and clots, that's why the
Okay.
study was pulled. But the study, versus absolute risk, which was, thought to be was said to be 25%, risk, so the media went crazy with
Wow,
this
that's
information.
that's a lot. That's 1 in 4.
1 in
Wow.
4, but when we actually analyzed the relative risk data, it was actually 0.08%
Oh,
risk.
wow.
So, with that misinformation, we'll call that, it really created this frenzy of fear and
Mhm.
anxiety amongst the medical establishment, and women weren't able to get their HRT when they were finding that was helpful for, hot flashes, night sweats, genital urinary symptoms,
Mhm.
all the things that you were listing here.
Yeah, and even, like, cognitive issues, like osteoporosis, like, all these things that once our hormones as women kinda, like, drop off the cliff, we are at much, much
Yeah.
higher risk for.
Absolutely. So that's how I started my practice
Mhm.
21 years ago was women like flooding the clinic door saying, I need help. My doctor won't give me HRT. So
Right.
I wasn't planning on, I wasn't planning on being, someone who really had passion and love for menopause until I saw so much suffering,
Yeah.
unnecessary suffering happening. And they were asking for bioidentical hormones. So what I've seen in my practice, we'll get back to now what the studies are showing, but
Mhm.
what I see in my practice is that it's a game changer for men and women who are suffering from decline in estrogen and progesterone, and then for men in testosterone. So as
Mhm.
you mentioned, you see the cognitive decline, you see fatigue, you see disrupted sleep.
Oh my gosh, the
Re-
sleep is such a problem for menopausal women.
oh yes, and when the sleep is disrupted, that also increases the risk of obesity,
Yeah.
of heart of type 2 diabetes. So so the first reason why I was so passionate is because I wanted to reduce suffering, and I started
Yeah.
to see tick and high cholesterol, high blood pressure, high blood sugar, and hemoglobin A1C, and women were really, really frustrated with, "I'm gaining weight. I've got all this belly fat.
Yeah, I've
I
changed nothing, what the heck? Yeah.
Yes, yes, I'm eating healthy, I'm doing, the right things, I'm exercising, nothing's working." So that frustration really was I just felt so much compassion, like, I wasn't in menopause at that time, I'm heading
Mhm.
into it now. So what it helped me really step into is understanding the research, attending conferences, like, really understanding HRT, and we're seeing is that, gosh, now they're revisited that Women's Health Initiative study, and they said, well, there's some flaws here. The flaws are, well, so the flaws were the results were overinflated. The risk was overinflated, but also women were being the study subjects were at an age above 65. Typically,
Okay,
there
which
was a
is much usually people go through menopause a little earlier than that, so
yes, yes. The average age of menopause is age 52,
mhm.
actually. So we're going to talk about the timing of HRT as well.
Because that's really important.
Very important, and the type of hormone therapy used. At the time, synthetic hormones were used,
Mm,
so MPA or medoxyprogesterone acetate was used, so that's a type of synthetic progesterone from urine of pregnant horses,
mm.
conjugated equine estrogens. So what they're finding is there's a lot of factors that can affect the benefits of HRT and the risks of HRT. Age, when you start it within 10 years of menopause is found to be most protective. And the type of hormone used. So we're seeing
Mm,
that bioidentical hormones that are derived from plants, yams or soy, that is bioidentical to us has less risk factors. So I do see that. I'm so encouraged now because now 20
yeah,
years later, we're seeing this menopausal movement, right?
right.
And a retraction of this overinflated risks that was
Mm.
causing so much fear and gaslighting in our community.
Yeah. Well, like, what's so important too, I think, for our listeners to understand is science changes. It said, hey, look, this is what we found. And then we realized, oh, that actually the way they went about the study wasn't great. The way they did the statistics, not so great. We need to really look at this because women are really suffering. And can we, well, there's probably some financial incentive there because I know bioidentical hormones are not the cheapest thing, but can we help them by reducing their suffering, which is why you wanted to get into this field? Science changes. We need to be okay with the evolution of science.
100%.
Yeah.
Science changes. I mean, back in the 70s, 80s, 90s, estrogen was like all the
And
rage,
we were
right? And
using a lot of it.
we're losing a lot of it synthetically, you
Yes.
know. And then these studies came out saying, wait a minute, hold on, we're seeing an increase in as breast cancer and stroke and heart attacks. But what we're and clots, and what really we need to look at is timing is everything.
Mhm.
The type of hormones used is everything. Even whether we pair estrogen and progesterone together can
Mhm.
affect. So what we're seeing with estrogen alone is that it had a protective effect of breast cancer, which is so right backwards. I still have to kind of wrap my mind around.
What? That's
Yes,
interesting.
very interesting data from all these clinical trials, even in the Women's Health Initiative study. It is now we're going to be, all surprised here is that progestin
Right, this
paired with estrogen can slightly increase the risk of breast
interesting.
cancer.
So progesterone's what's mostly found in birth control though, right? Like that's not what we're using in hormone replacement
Exactly.
therapy.
We're
Aha.
not using we're not using progestin, we're using oral micronized progesterone, which,
Yep.
all has a lower risk compared to progestin.
Yeah. And so like good for people to know is like your doctor might say on your birth control pill, oh yeah, it's just progesterone and estrogen. That is not true. They are different chemicals. Nuance in this case does actually matter.
It does, it absolutely does. So and what they're seeing is within the first 5 years, we're not seeing that risk
Hmm.
factor, right? But after 5 years, there is a slight risk. 1 in 1,000 women has an increased risk, but with progestin. Now we need progesterone. I call it progesterone is what we use, oral micronized progesterone paired with estrogen protect the lining of the uterus.
Uh-huh.
So estrogen alone should not be used unless a woman has had a hysterectomy and no longer needs that protective effect on the lining. Because
Yeah.
estrogen does increase the lining, the uterine lining, and so there is
Exactly.
endometrial cancer risk. So what we're seeing is pairing estrogen and progesterone helps reduce the risk of endometrial cancer.
Yeah, unfortunately, I've never seen in my practice a woman prescribed just estrogen. I have seen progesterone just prescribed.
Right?
Different
So
though.
yeah, it's different. And I mean, progesterone is so effective for
Mhm.
calming the nervous system, helping to promote sleep, right? It stimulates
Mhm.
GABA receptors, gamma aminobutyric acid,
Mhm.
to help with that calming effect.
Which is
It's anti
it's a calm down
it's a
neurotransmitter.
chill. Yeah,
Yeah.
it's a chill hormone.
Mhm.
Estrogen has more of a serotonin receptor kind of, it increases the serotonin receptors,
Mhm.
so we're gonna see more mood elevation, more the brain fog is real in
Yeah.
perimenopause, those memory lapses, so it really helps to improve brain function. We
Uh-huh.
can get into kind of the research on the dementia as well,
Yeah.
but what we're seeing is it's the pairing of the 2 that we need to be mindful of, right? But the risk is very still quite low compared to the risk of breast cancer with alcohol consumption or obesity or
Mhm.
smoking. So
Mhm.
it's so interesting. And what is the number 1 killer of women?
Cardiovascular
Uh,
disease.
cardiovascular disease.
Yep.
1 in 2 women, 2.6 women die of cardiovascular disease, which is much, much higher than the rates that we see with breast cancer does.
Yeah.
So it's just, I love looking at like questioning the status quo.
Mhm.
And again, I got into this because I really didn't want to see any more suffering, but also we are reducing the risk of chronic disease when we support women's hormones.
Mhm.
And you know,
So
I definitely feel that. Oh, so my passion then, so it evolved, if you don't mind me sharing
sure.
more, is that my passion evolved into, gosh, we're seeing reduction, 40 to 50% reduction in cardiovascular disease,
That's pretty
heart.
substantial.
Yes, when used properly, the timing hypothesis, you need to start HRT within the first 10 years of menopause, even before you hit menopause, right? And we'll talk
Mhm.
about what happens after if you're not in that window.
Mhm.
Um, it reduces diabetes, type 2 diabetes,
It
by
make
about 30%,
yeah,
right?
makes sense.
Reduce dementia by 30%. Yes, osteoporosis. We will see a decline in hormones about 20%, or decline in bone density at 20% decline when women go into perimenopause, menopause. And
Mhm.
what's another mortality factor for women?
False.
Fracture. Yeah,
Yep.
hip fracture.
Mhm.
Right? So we incur a 20% risk of mortality when we have a bone fracture in the hip.
Yeah.
Second fracture, 50% increase in mortality.
Yeah.
So it's like, I mean,
We're cutting
and
risks across the board in multiple
yes,
systems and taking better care of women, which, there's plenty of data that shows women have to go to the doctor, a half a dozen more times than men, blah, blah, to get a diagnosis and be
mhm,
believed. I've had a couple cases this
yes,
week that have just like, oh my God, are we still here? Um, the thing that I want to, you keep mentioning this, like the timing really matters.
mm,
So during perimenopause and in menopause, the timing matters. Can you talk a little bit more about that and why that's so important?
yes. So the timing matters. And what we're seeing is that with these, very large randomized controlled studies, the studies that are done on women at the age of 65 and over, and like you pointed out, Dr. Shana, that we're well past
Oh,
menopause by
yeah.
then, right? About at least 10 years,
Mhm.
is that there is a increased risk of heart disease and strokes when started later. Now, there's something about this healthy cell hypothesis that when the cell receptors are still, used to having all these hormones circulating in our system, because prior to perimenopause, menopause, and menopause, we are creating, an optimal amount of hormones, ideally,
Ideally,
in
yes.
during, yeah, particularly during pregnancy, right? So what's happening is that if we wait too long, the studies show that, after 65, there is an, potential risk of more dementia, more
Mhm.
heart disease when hormones are used at that time. But within this 10-year time frame, within the late 40s, mid 50s, there's actually a significant reduction in cardiovascular disease risk, 40 to 50% reduction.
Mhm.
There's a reduction of all-cause mortality by at least 20 to 30%.
Wow.
All-cause mortality meaning death,
Right.
right?
From all
So
causes, regardless what, the cause is. You're playing on the monkey bars, like you're less likely to die on the monkey bars.
exactly. So the timing hypothesis is what they're seeing is women and within this age group had like really saw a significant cardioprotective
Mm.
effect,
Yeah.
neuroprotective effects, reduction of dementia by 30%. The FDA has obviously approved the use of HRT for osteoporosis treatment,
Mhm.
but this timing is key because these cell receptors are much more responsive
Yeah.
to the hormones. And after that, that's where we get a little bit like, what's the gray area here, right?
Mhm.
After that, if a woman hasn't been on HRT, and most of the women I see who are in their 60s are like, my doctor told me I can't take it, it's dangerous. And I wish I had more information. I wish I had someone to advocate for me and give
Yeah.
me more information. And that's what's heartbreaking to me is that these women missed an opportunity that was so important to
Yeah.
use these risks of degenerative diseases that are not just age related, they're hormone related,
Mhm.
hormone decline related. And so the thought is that if you there's, this, as you said, science research is constantly evolving.
Yeah.
The thought is that if you are in this group, there was a staunch kind of like, nope, absolutely not. You cannot do any HRT. But now there's a little bit more wiggle room.
Right.
Have you had a heart attack? Do you have a family history
Mm.
of dementia? Do you have dementia? Do you have clots? Those are absolutes. We probably need to say no. Well, let's use herbal nutrients. Let's use
Yep.
herbs and nutrients. Let's use lifestyle diet. I would say those pillars as a naturopathic doctor are the most essential.
Yeah.
HRT is adding more support, longevity, quality of life. But if we have a population of people who may not be a candidate or breast cancer, for example, if they
Mhm.
have positive breast cancer, I'm definitely gonna be much more cautious and maybe do more, testing or do the herbal nutrient route.
Yeah.
Right, but the gray area is if you don't have all those risk factors, it's recommended to consider doing a coronary calcium score test.
Nice.
Yeah.
Okay.
Keep an eye on yeah, so coronary calcium score test basically is a CT scan looking at calcifications in the arteries to see if you are at risk for developing a heart attack.
Yeah.
So or heart disease or stroke. So if you don't, you have a score of 0, then that may be a conversation for that may be something to consider.
Yeah.
Yeah, or the blood pressure is controlled, there's no risk of clots.
Right.
So that's something where I'm starting to if we there's a really wonderful book called The New Menopause by Dr. Marie Claire Haver. Heavy she really provides a ton of evidence, and that's where I thought, "Okay, let me be a little more flexible," because I was pretty rigid too about certain things before about
Mhm.
whether person was a candidate for HRT, and now we're saying, "You know what? Do the risks the benefits of HRT
Yeah.
outweigh the risk." So if we
Yeah.
do the proper screening, then we can have that conversation and with
Totally. Yeah,
that
risk assessment, and then I like
yes,
that you throw in this coronary calcium score because then that tells us, okay, what's going on in your body. You have this family history. You haven't had a primary cardiovascular attack, which is heart attack, a TIA or a baby stroke or a big stroke. You haven't had those. Let's check your plaque buildup then. That's
yes,
fantastic. So then
yeah, absolutely,
so then what about like the different routes of hormone therapy? Like there's patches, there's pills, there's
yeah.
pellets, there's shots. Pros and cons, did like any of them that are completely off the table or ones that you prefer over the others?
Yes. So I was a kind of a purist. I was only as a naturopath, we tend to be like that.
Yep, we
Like
do.
I'm only going with compounded. I'm only going with,
Yep.
IS, which is estradiol and estriol cream. I'm only going with progesterone cream. And as you shared, Shana, the Dr. Shana, this research is continuing to
Oh,
evolve.
yeah.
So I became, I wouldn't say less of a purist, just much more open-minded about looking at all the different options,
Totally.
right? And I do monitor people's hormones, so that's like a really important, I think, piece of this. Some docs say you don't need a test. Some docs say, it's not necessary. But for me, it gives me kind of a framework as to is it too much? Is it too little?
Yeah.
So so back in the day, I you know definitely prescribed a lot of, HRT in terms of it's gotta be estradiol and estriol cream.
Mhm.
Um, Start low and then increase depending on what the benefits that the patient is receiving, the lab levels, and we'll talk about labs, later in the conversation. And I always prescribe progesterone cream. So what I'm seeing is now that there is there's so much momentum with the offerings available because back
Mhm.
in the day, we had synthetic hormones or compounded hormones.
Right.
And now we have the patches. So what estradiol patch. So what I found with the transdermal route is that for some people who maybe aren't absorbing the cream as well, and it does depend on, how absorbable the cream is, how often the patient's switching sides monthly. I find that when people aren't really responding well to the creams, I'm moving over to the patch, and I do see a much more consistent absorption of estrogen.
Okay.
Estradiol. There's no estriol, but it's estradiol, and they're getting like better results for those who aren't responding well to the biased cream. And the other piece of the progesterone is I was, like I said, a purist with just using progesterone cream. It still has great benefits, but what we're finding is the oral micronized progesterone is much more protective for the uterine lining
Yeah.
and make sure that endometrium is healthy, right?
Mhm.
And not thickened, and there's that risk of endometrial cancer.
Yeah.
So what I'm finding is, yeah, my prescription kind of uh, standards are also evolving as the research is evolving,
Totally. And
and you have to tell you, this is out of pocket. So my patients are asking for, can you help me save some money and see if my insurance will cover it?
yeah.
So estradiol patches, and oral micronized progesterone through Prometrium, maybe not as the Prometrium is not as clean, but it is covered by insurance.
Right.
Clean meaning there's more fillers, there's dyes. So I always give patients options, right?
Exactly.
You want to go the
Mhm.
compounder route, we have much more flexibility with dosing. We don't have to be just, stuck with 100 milligrams or 200 milligrams of Prometrium.
Yeah.
Kind of, gradually increase the dose. Because
Mhm.
I like to start low and slow
Yeah,
and
because
find the most
I've
therapeutic.
I've definitely had patients have issues with progesterone, and, like, out of all the things, it's like, "Oh, yeah, prescribed for sleep," but they get thrown on, like, 100 or 200 milligrams, and it just might be too much, and if perhaps it had been compound and they got 20, would they have been a better, like, response rather than, like, I feel overstimulated and, like, anxious, and it's, like, too
Yes.
relaxing for their system.
Yeah, or they could have the gastrointestinal effects because it is an oral route,
Totally, totally, I
like
have
the
seen that as well.
Yes, well, I'll just share a personal story with you because, I do suffer from insomnia. I've worked on it all my life, and now that I'm in perimenopause, the proge the I really want to be on progesterone,
Yeah.
and I think it started a little too early because it converted into testosterone, and then I had this amplifying effect, right? But that
Uh-huh,
was in mid-40s, and I kept checking my hormones, and everything looked perfect. I said, "Oh my gosh, I can barely function because 'cause I'm not sleeping."
uh-huh.
And I patients all day, I literally it was affecting my functioning. So, I decided to take a small amount of progesterone, like you were saying, I started with 25, 50, and it worked really well.
Ah.
What it taught me, Dr. Shana, is that I was heavily relying on labs. And just because
Mm,
the lab results are perfect doesn't mean that we
no,
should not consider hormone therapy.
no.
That was a big lesson for me because what I'm seeing more is that, because I do serum testing, blood work,
Okay.
uh, and we're getting snapshots. I'm,
Oh, yeah.
definitely the peaks and the valleys. So I'm not just checking one, snapshot within the cycle. I try to get, an idea of what's happening within the cycle.
Mhm.
I feel like sometimes we rely too heavily on the labs and we're not listening to the patient. What is
Yeah.
going on for you?
Yeah, symptoms matter, both. It's like I want
They both matter.
labs to be in a
Yes.
good place, not too crazy high, not too crazy low, but then, I talk about this with my thyroid patients. It's like, I don't care if your thyroid labs look perfect. You're having thyroid symptoms, something needs to be changed. We have to address something.
We change. We must because that would then be feed into the whole gaslighting where, well,
Yep.
everything's fine, you're fine, right? And as even, naturopathic doctors, we're doing the proper testing,
Mhm.
and sometimes I get stuck in that model.
It's
So it
easy
helped. It was
to.
a really it was a really good eye-opening experience, and so I'm obviously getting more people who are like, "Wow, that was you were willing to think outside the box and provide me with some low dose HRT." Because we tried all the things like, nutrients and herbs. I
Mhm.
always go there first, lifestyle, diet.
Totally.
I need more help, and I feel like it's been such a relief for women to feel like, "Oh, you're listening, you're understanding, you're willing to think outside the box," and I think that's what, naturopaths, Western doctors, that's so important for us to
Mhm.
not to get stuck, in our box.
100%. Yeah, and it's like in Colorado, I have no script authority, but I get patients asking questions all the time about HRT and how do I know who to go to? And well, my doctor told me I'm not a candidate. And
Mhm.
that was the end of the conversation. So how do they know who to go see to ask the question about? Ask the question to.
That's such a great question, and I think it's so common, and
Mm-hmm.
those are the folks that come see me, right? But they gotta do the research to get referred.
Yeah.
So I believe the first thing is to, yes, advocate for yourself. If your doctor isn't willing to work with you and has kind of shut the door, not thinking outside the box, you're not in menopause yet, you haven't had 1 year of no periods, you're not a candidate, hormones look fine, even if maybe the testing isn't, very
Great. Yeah.
thorough. Right? And that's a common one too. My doctor won't test me
Yeah.
for my
100%.
hormones
See
because
it.
I'm
Yeah.
or menopause is normal, so everything is fine, even though I
Mm-hmm.
feel terrible. Is that you definitely want to look at, your the medical community that's looking outside the box. So those are functional med doctors, those are
Mm,
naturopathic doctors. Because we're definitely more trained in women's health in the sense of looking at hormone therapy, looking at herbs and nutrients, dietary lifestyle medicine for the treatment of these hormonal shifts, which can be very uncomfortable, very disruptive.
mm-hmm.
So
Yeah.
first start with, a doctor who is integrative or who has that functional medicine or naturopathic background.
Background.
Second is to, you got to interview them, make sure that
Yeah.
they're doing the proper, continuing education because, you and I know, Dr. Shana, is that we had about a year of women's health and HRT training, kind of sprinkled into that. And we were so fortunate to have such an amazing, for me, I don't know if you went to Bastyr, but at
Yeah.
Bastyr University.
Mhm.
Yeah, okay, we had a really amazing women's health professor, Dr. Tori Hudson, who now offers continuing education through the Institute of Women's Health. So that's what I do. I do her hormone boot camp. I go to as many of her conferences as I can to stay up to date on the research. So it's important to have someone who's doing their continuing education in
Yeah.
women's health and HRT.
Yeah.
And now that there's a much more, like I said, there's a menopausal movement. The Menopause Society, formerly known as the North American Menopause Society, is like this, an organization that oversees all the research, clinical trials, and every year they create a consistent statement about the benefits and risks of HRT.
Mhm.
And so they're now called Menopause Society. So they do offer certification program. You can become a member and get access to, their conferences, their seminars, and the certification tests. So that's something that I'm stepping into and becoming more involved with
So
just because I want to
so what I'm
and grow.
hearing is specialty doesn't necessarily matter, though functional med and naturopathic doctors, we tend to be, more involved in this. However, what matters more though is our continuing education and like, are we women's health focused? Are we staying up to date on the research? Because like I said, I remember learning about that women's health initiative in school. And then it was my like last year when I was taking extra classes in women's health. And it might have been actually Tori Hudson that was teaching that one. I can't recall. They were like, oh no, like there's been a new study that's come out, relooked at it. And like, I kind of was like, end of school. So my brain was like, I'm done with this. But I remember hearing about it. And it's important that we're getting continuing education and we know what we're talking about rather than just writing our patients off and not listening to them. And I told my one patient that asked me this question, it's like, hey, doctors can't know everything. There's so much to know. And, maybe that doctor just doesn't know much. And so then just said, hey, like, this is not, no, it's a no for you. It's a no for you from that doctor, but seek out additional opinion is what I recommended.
We got additional opinion 100%. And, many more books coming out now. Like I said, I
Mhm.
mentioned Menopause by Dr. Marie Claire Haver, and she's really prominent on social media. So I'm so glad we're doing this so we can get the word out even more.
Yeah.
So there's books available. There's a list of Menopause Society members who
Mhm.
are trained in HRT. So that's another great resource. And, talk to your friends. I think back in the day, we didn't talk about menopause,
Right.
vaginismus and low libido. Oh my gosh. And like now we're seeing that things like vertigo and tinnitus and frozen shoulder,
Yeah.
and hip pain, those are signs of potential perimenopause and menopause.
Mhm.
So it's so important to not just discount how you're feeling. You
Yeah.
need to ask for help and advocate for yourself, talk to your friends. So now there's much more conversation about it,
Mhm.
and people are feeling much more heard and supported. What are you doing for your menopausal symptoms, right?
Yeah.
So it's so important to talk about it rather than just repress the symptoms or just say, you know what, it's just part of aging. And I think that's what the downfall is this is just normal. And what's happening is that we are thankfully living longer, right? We are living at least 20 to 30 years and longer in the menopausal state.
Mhm.
And I'm all about quality of life. I'm all about preventing these chronic diseases that can cause even more suffering,
Right.
hospitalizations, use of medications, right? So we're in this time where it's like we're living longer, so let's make this quality of life really matter for us so we can continue to live purposely,
Yeah.
living. Fully.
Yeah, not necessarily in a wheelchair and like forgetting your family members, right? Like there's definitely pros and cons that need to be weighed and when we're having these conversations. Now, you mentioned that, labs are not the end all be all, but you do run labs. The time that I encourage people is like 3 months when we're initiating treatment and then maybe it can go a little longer thereafter after things we've found the dose that works best for that person, the way they're feeling and their labs look pretty good. What do you think?
Yeah, I think that's, everyone kind of has a customized way of practicing,
Mhm.
what they find is most beneficial. For me, I agree with that as well. Well, I usually will do baseline labs to kind
Yep,
of get a sense,
makes
you know,
sense.
yeah, baseline to see where we're at. And then I'll recheck in 3 months. Usually we'll see, but typically I'll see people have a major shift, particularly in hot flashes and night sweats within the first 2 weeks of HRT.
Definitely.
But I honestly, like I said, I do use other resources. I mean, that's our toolbox is so large,
Yeah.
right? But like so I oftentimes will use something like da huang or Chinese herbs or maca root. That's besides the point. So I'll check within the 3-month mark to see how the patients responding to the hormones? Are we seeing an uptick? Now, I do notice that progesterone doesn't increase as much. You're going to see more in the progesterone, the free levels in saliva. You see the metabolites and the urinary testing. But
Mm-hmm.
for me, I find that blood work is easier to track for a lot of people, and it
Yeah,
gives us feedback immediately.
it does.
So I check in 3 months, and then I usually will, once we find the sweet spot, we'll do every 6 months. But I'll tell you, perimenopause is a journey. You're gonna
It's
see.
a lot of peaks and troughs, very sharp
Yes.
sometimes.
Yes, where you're gonna go through maybe a drop in progesterone and a spike in estrogen that
Yeah.
happens. You'll see maybe drop in testosterone, a spike in or testosterone. So some women go through like puberty again. They start experiencing,
Yeah.
acne, facial hair. So everyone's different. That's why it's so important to meet everyone as an individual.
Yeah.
And the blood work is helpful because it helps to customize that, type of care, but also, as we know, listening to where they're at. But it's a journey. And so I'll have some people who are doing fine
Mm.
for the year or two, and then boom, maybe they have a stressful event, maybe they're fully into menopause, or their diet's off, their sleep is off, and their symptoms are so they come back, right? So
Yeah.
then we got to adjust the hormones or adjust their lifestyle diet. Um, so I do like to maintenance. I oftentimes will check every 6 months or
Yeah.
so,
That
and
makes
that's counter
sense.
to some other docs who don't test at all. But I like to have
I
that
mean, it
information.
changes. Is like we've seen the graph of menopause. Like it is not a gentle graph. It's very
No, it's not a
sharp.
straight shoot. Yeah, you don't
No.
need to go from 0 to, or 100 to 0.
No, andropause is much more of a gentle decline relative to menopause with the
Oh,
sharp
for
peaks of
sure.
things. So it's like, I do think the 6 month testing makes sense. And again, listening to our patients and their symptoms that they're having. They're in your office again telling you, man, my weight was stable and I've gained a bunch of weight in the last couple weeks and my sleep is off. They're going to be telling you these things. And it's like, if we're not listening to them, we're not
Yeah,
trusting their lived
right.
experience, we are not doing a good job. And I will say that strongly because we really, as the medical profession in general, need to do a better job listening to our patients.
100%. That's why I think for me, like just having more time to spend with people,
Uh-huh.
like really doing a thorough assessment, listening to their needs is so key. We're very intuitive beings.
Mm-hmm.
I honestly, that I really believe that listening to your patient, they have so much intuition and they oftentimes know what's happening,
Yeah.
and we just need to create a safe space for them to express that because
Yeah.
oftentimes, an average visit with a Western doctor, maybe 15 minutes if you're
If
lucky.
you're lucky. Yeah.
If you're lucky, it's a
Mm-hmm.
7-minute average.
Mm-hmm.
So that's why I think we as naturopaths have the ability to spend more time with people and really dig deep and understand what's going on and get to know,
Yeah.
what are they eating? How are they sleeping? What's happening in their life? Because stress 100% affects our hormones, affects
Stress.
our adrenal glands.
It's killing us. There's a
Yeah,
lot of things about American culture I love. The go, go, go. You get 2 weeks of paid leave and that's it for your entire year. I'm like, how? Like,
I
that's
know.
not stress relieving at all. And like,
No, there's so much hustle and bustle, so much
yeah,
pressure to perform and succeed. And I hope
hmm
that we're shifting out of, again, that's an old model,
it
right?
is an old
Shifting out of
model.
that. It's oftentimes coming from a place of a lack of
Yeah.
worth and placing external measures of worth upon us.
Mm-hmm.
But yeah, so I do believe that, yeah, having all those pillars in place is so key,
Mm-hmm.
detoxification, liver support, gut health,
Yeah.
um, movement,
Mm-hmm.
nutrition, which will shift as we go into perimenopause,
Yeah.
menopause. If we're going to be more at risk for high blood sugar, high cholesterol, hypertension, weight gain, belly fat, we gain more weight because estrogen, when it declines, progesterone as it declines, it increases. Well, it actually affects these enzymes that cause us to gain more fat,
Mm-hmm.
which is so interesting because where do our hormones get stored? Primarily in our fat,
Yeah.
right?
So then it kind
And so our
of,
body's
yeah,
just trying to balance itself out.
totally.
Yeah.
And it's like
So
I've tried to explain this to some women, and like I had one woman push back. She's like, "Just wait till you're my age." It's like there is a little bit of value, and I don't know if you agree with this. Is like if you lose too much fat mass, as you've gone through menopause, that affects your hormone levels and how a woman can feel. Like we need a little bit because my understanding is that it helps us for a couple reasons. One, reduce our fall risk for breaking, fracture, and two, it's kind of our like new source of estrogen storage because our ovary reserve isn't there anymore. So it's not the best, it's not the worst, but it's better than no estrogen storage.
Right, and I mean, and the adrenal glands do
Sure.
also kick in. When I
Yep.
say when the ovaries go on vacation permanently,
Yeah.
and then they produce dehydroepiandrosterone, which converts into testosterone and estrogen.
Uh-huh.
But I agree, it's all about, kinda like hormone therapy, the type of fat, right? So if we're getting more visceral fat, belly fat, that's going to increase our risk for metabolic disease, like
Right.
type 2
Right.
but if we have more, subcutaneous fat or a healthy level of it with good muscle mass,
Yes.
that's gonna create more balance for our bones, for our hormones,
Mhm.
um, and prevent the risk of fractures, like you said, because our lean body mass is so essential to keep all those bones healthy.
Yeah.
And as we said, there's a 20% drop in bone density when our hormones decline. So
Yeah.
yes, we do. I think we're in kind of this. We've been in this culture of skinny is best, right?
Yeah.
And now we're in this whole age of GLPs, and I see a lot of concerns with excessive loss of muscle mass,
Yeah.
and I'm concerned about it. So we really stress protein. We really stress strength training,
Yeah.
making sure.
Necessary. Like if you're on a GLP-1, you have to be doing those things. It's not optional, it's not
Oh
secondary,
yeah,
it's required. I am definitely
it's
concerned about that too. Is like the sarcopenia thing, the loss of muscle mass is like I didn't learn that muscle was a metabolic organ in school. It was after school that I like started digging into the research and I was like, "Oh my God, like this is such an important thing." Like, yes, we go through our hormone loss, but we're not especially women and depending our age like we've kind of some of the older women are like saying hey I don't want to be buff. You're never going to be buff like a man because we don't have that kind of testosterone, but
yeah,
like you need to lift some weights. Like you've got to be picking, and it doesn't have to be heavy, but like if you're only picking up a 3 pound weight, maybe get to the point where you can do some 10 pound weights. Like just keep using those
absolutely.
muscles,
Keep
man.
using those muscles. It doesn't. You can hike up a hill.
Hike up a hill,
Start
exactly.
hike up a hill. You can do some jumping, trampolining. There's so many ways. Use bands. And I do
Mm-hmm.
think that's the case is like so when other symptom of menopause is fatigue.
Yeah,
Fatigue,
it's a huge
lack of
one.
motivation. So it's so hard to like be motivated to do the things that are good for you, right? Because you still
Mm-hmm.
have to have those pillars in place. So once women start feeling better, they're sleeping better.
Yeah,
Men too. I haven't really talked about men a lot, is that they're much more motivated to stay on top of their lifestyle and diet.
100%.
So that's what I see is that, kind of it's feeds upon itself. When you feel better, you want to do more. And when you start seeing the metabolic health improve, right? You see that you're gaining more lean body mass, losing the belly fat, then there's much more encouragement.
Totally.
See that with hormone therapy, most women gain about 5 to 10 pounds in menopause, sometimes more if the diet and lifestyle is not in place. But what the research is showing is that it can stave off that excess weight gain for sure and redirect, we're not gaining the belly fat. We're seeing
Mm-hmm.
a much greater loss in waist circumference, which is so important for preventing those diseases as
Yeah.
well. Dr. Sheena, I didn't really get to, can we go back to the different types of administration of hormone therapy? I think that's,
I was hoping you were gonna talk about pellet therapy.
yeah, I was talking about like, what I like to do, but I do want
Yes.
to touch on what I feel like can be less beneficial.
Mhm.
Is that oral estrogen does incur more of a risk for clots.
Yeah.
And it can increase C-reactive protein, which is an inflammatory marker. So I do, and hormone replacement therapy is very different from oral contraceptives. So I'm much more well versed in HRT, but I do steer away from the oral estrogen. You're not going to see a lot of that unless it's like a sublingual, then it goes more into the bloodstream,
Mhm.
and then it has to get broken down through the liver. I make an exception for oral progesterone, and we're not seeing those inflammatory effects.
Yeah.
Um, but it's the research showing it's most protective for the uterine lining and most effective for sleep.
Yeah.
Um, uh, Now injections, that's we're going to get in the territory for most of the time. We don't use injections for women, but for men, I do see men who are on testosterone injections, and they're going to get much higher levels of testosterone. So we want physiological doses that are appropriate for the age, so that's why the labs are important to look at, so I'm looking for an optimal response through the
Mhm.
lab as well as through the outcome as well.
Yeah, symptom
So
presentation.
for the symptom presentation. So for women and men, I oftentimes will recommend creams, testosterone creams, which is really great. We talked about sarcopenia for preventing lean body mass loss, muscle mass loss, but it's also great for motivation and libido.
Mhm.
Um, Injections, again, I said, tend to have more super physiological responses and then or effects. And then we look at the pellet therapy, which in most naturopathic kind of communities is thought to be too excessive. And I'll tell you, I do get people who've done the pellet therapy route with other practitioners, and they're like, "Oh my God, I have hair loss and acne. I'm turning into a teenage boy,"
Yeah.
and I don't feel good, and it's scary. I felt great the first 3 months, and now I feel terrible because it takes a while to process those hormones to detoxify them. So I do steer away from pellet therapy because I do think it's harder. Pellet therapy is a subcutaneous insertion
Mhm.
of um, hormones, and it's harder to adjust the dosing,
Right.
but it's also getting much higher superphysiological doses,
Yeah.
which I think will incur more of side effects, more risk factors.
Yeah, the way I describe it to patients is like, okay, you usually get a pellet every 3 months, sometimes a little less, just depends on the practitioner. The first 2 weeks, you are ripping with hormones, and then you kind of plateau off for the next, like, 6 weeks, 6 to 8 weeks, and then you start to come down, and then you don't have enough to kinda sustain you, and you start having maybe some negative symptoms again. It's like, I've seen that multiple times. Pellets are very common in my area from the different
Mhm.
hormone offices, and I don't love them. I don't think that they're the best way to go about it for patients, and I'm trying to tread carefully because I know many ways to skin a cat, and I wanna respect it, but just the patient population I see, they don't seem to do the best with pellets.
Right. Right, and I think if they did well and we're seeing, gosh, the numbers are in a safe, healthy place and
Yeah.
there's not that drop off, that's a great point too. And then the need to process all these hormones because I always, we were talking earlier, it's gonna go somewhere. These
Uh-huh.
hormones has to get metabolized somehow, right? Is it going to be, healthy metabolites or unhealthy metabolites? And it's so
Mhm.
important to have that proper liver support and dose properly and have those pillars in place. So I know that it works great for some practitioners. For me, because I do have some control issues, is I want to make sure I know what's happening day to day.
Yeah.
They're getting a steady stream of hormones. I see the benefits long term,
Mhm.
right? And I'm definitely seeing that the number of hormone levels are improving, but also what I'm seeing is the blood sugar comes down,
Yeah.
the cholesterol comes down, right? They're feeling better. But so yeah, going back to the modes of administration, there's different ways to administer hormones. What I find that is for my practice, what's safest, what's easier to monitor and adjust, and I always call to get to the sweet spot is through either creams or the transdermal route with
Yeah.
estrogen, and then oral progesterone if there's a sleep
Yep.
issue. And if there's no uterus, then we may not use progesterone. But if they're suffering from insomnia, anxiety, I'm gonna have that patient consider it.
Yeah, totally. That all makes sense, and, I I'm so grateful for our education at Bastyr because I feel like even though I'm not in that world, I this is how I was taught, and so I am grateful that, like, hey, have been educating my patients is similar to your philosophy of, like, much more years in practice, so thank you for sharing with me, and,
Yeah.
before we hopped on the call, we were talking about, hey, there was a black box warning on HRT, and it's gone now in the last
Yeah.
month. That's amazing, and it's such
Hooray!
exactly, like, the evidence has changed. We have learned something different, and we are now going to be able to provide women and men with better health care and support them through their hormonal transition.
I I 100% agree, and that says a lot. Like you said, we were evolving, we're growing, as human beings, but in research and science,
Yeah,
and that removal of the black spot warning that hormones cause cancer and strokes and heart attacks, dementia, that's been removed. There
yeah,
is still a warning about the endometrial cancer.
yep,
It's for just estrogen alone, but that makes 100% sense.
yep,
But just now we can, this new generation of women who are going into menopause. I think what was the statistic? About a billion of there'll be a billion women in menopause,
oh my
right?
gosh.
Year is that I think that's a correct stat, but is that we need to have resources available,
Yeah,
whether or not you decide to do HRT or not. We need to have that conversation
yeah,
and remove the fear, removing the gaslighting, removing the just like I said, the overinflated
Yeah.
concerns. Now that the research is showing that, hey, it actually is going to reduce your risk of death
Yeah.
and it's going to livelihood is like, oh, what a relief
And yeah.
that these new generation of women are coming in with that support,
Yeah.
that advocacy,
Some better care.
that
It's like you
better
can't
care.
blame the old docs. It's just like now we know let's do better. That's how medicine works.
100%. And
Mhm.
I think that's why we're all here. We want to
Yeah.
do better. We all want to live fully in our purpose. We want to grow as human beings. And as doctors, as patients, that's what we're doing. Right. And
Yeah.
I have to tell you, I learned so much from
Oh
patients.
my god, so
They're the
much.
ones that are, challenging me. Hey, did you hear about this research? Did you read this book? And I'm, trying to stay on top of it too, but I love learning from patients. And
Yeah.
so it's that's why we call it a practice,
That's
right?
right. That's right.
Yeah.
Any other final thoughts for our listeners to debate today? Hormone replacement therapy or other?
Um, I think we talked about a lot of things. What I
Mhm.
would say is don't give up. If you have felt kind of like maybe it's too late for me, maybe I'm out of that window. Um, I'm so frustrated. I'm just gonna go ahead and just suffer. Change that change that mindset. Know
Yeah.
that we're here for you.
Yeah.
Know that we're available. There's an amazing community of doctors who are like me 20 years ago are becoming passionate and excited about, women's health and hormone therapy. So don't feel discouraged. Know that there's hope for you. There's healing available to you, and there's so much we can do, and that even if you're not a candidate for HRT, there's so much that we can do with the pillars of health.
100%.
Have those intact. We're here to help support people with that, because I
Mhm.
know it can be a lot of misinformation, over information, right, on social media. It's
Definitely.
yeah, create your village, your tribe of people to support you. And, thank goodness naturopathic medicine is here to advocate for those who are feeling like unheard, who
Yeah.
are feeling like maybe there's no hope for me. I don't want to I don't want to be neglected or dismissed. I don't want to use medications. I don't want to be on Zoloft for my menopausal symptoms.
Yeah. Oh
There's
my god. Yeah.
so much more available to our
Mhm.
community. So I hope this conversation can inspire women and their families and men too. Sorry, we didn't talk about men as much, but
Sorry,
that,
guys.
yeah, guys, well, maybe another time
Mhm.
is that there's hope for healing and there's a really big toolbox available to all of us. We just need to, you know, just keep asking questions, reach out for support.
Yeah.
You'll find that tribe. You'll find that village.
Yeah. So, just a quick summary, guys. HRT, there was a study that was done 20 years ago. It was a little conflated. We used the wrong kind of statistics. Statistics matter, and how we look at them also matters. And most news organizations maybe don't have statistical education training, perhaps. I don't know. There are lots of tools that we, as naturopathic doctors and even functional med practitioners, can help our patients with. And, we talked about the pillars, although not in detail, but those are critical to have in place while you're considering HRT. And the best kind, at least what Dr. Tang finds in her practice, patches and creams for estrogen and testosterone, and shots too, although less common it sounds like, and then oral progesterone. So if you have questions and you're trying to find a practitioner, it's going to be really important that you look for someone that has continuing education, or ask the question. A lot of us have discovery calls and you can say, hey, are you staying up on continuing education? Are you familiar with the latest research on hormone replacement therapy? And don't be discouraged by asking one opinion and someone closes the door and say, okay, well, they might just not know. And just give that doctor the benefit of the doubt. And if you have any questions or comments, or you were offended or annoyed by something we talked about in this video, drop a comment. That's how we create a conversation and learn from each other. And if you found this video helpful or interesting, share it with someone, or like and subscribe. That's how I know I'm doing a good job with my channel and providing good information to you guys. And Dr. Suzanne Tang, I really appreciate you joining me today, and we'll be in touch.